Right. Thanks for that introduction, David. And David is certainly very responsible for any of this happening because he was involved in the process of developing this with the team at ICAFS at Hutt Valley DHB 4 years ago, from the beginning all the way to the end. What I'm going to do in today's talk is just describe how we developed what we call KPP Plus. There's a bit of humour in that title and relevance to other plus type subjects that some of you might know. Some of the results we got from the audit and a discussion of those findings, key findings, and also some recommendations that we've had for ourselves and for others for its future use. So just a bit of background. I'm not sure how many of you are familiar with the Hutt Valley DHB, but it kind of serves a population of about 140,000. About 30,000 children 0 to 12 years and 20,000 youth 13 to 19 years. So that's the kind of group of young people that we were looking to kind of provide services to at a secondary mental health service level. There are two teams, a child team and a youth team, and that's partly out of convenience that it's been set up that way, and roughly equal numbers of staff in each of the teams. The population-wise, from an ethnicity perspective, 70% Pakeha, 16% Maori, 7% PI, 7% Asian, and the rest. So probably not too different to most of the CAMHS services that you would all be working with around the country. In 2007, an external review of the service was undertaken because there were some problems in the service, and out of this, a service development group was created to resolve some of these and maybe promote some better service delivery. Around the same time, David was undertaking KPP with the adult services at Hutt Valley DHB, and I went to see, or some of us went to see a presentation that was being done by him and by Debbie Jordan, who's sitting in the front here, who was very much involved in our work as well, and thought, actually, this could be a good vehicle for getting some data upon which to base some of the changes we're thinking about making. Because when we brainstormed as a service development group what could be done, there were about 50 things that we came up with, and nobody knew kind of which was the most important or what would be the most valuable to start with. Now, with adult KPP, as David said, it's been trialled a number of times, and it's certainly got. It was originally developed for long-term service users. It's got a couple of distinct advantages. It's there's a specific target group that it's kind of designed for, and there's pre-agreed service requirements, so you know kind of what you're hoping to get when you're looking at the data to see whether it matches or not. What we were starting with was a population of young people who'd never been studied in this way. We didn't know what we should be doing, so we ended up thinking a bit more broadly and trying to stretch KPP, hence the KPP Plus. We did believe in the 10 key features of KPP, which some of you will be familiar with, so it's a very busy slide that's up there. And I won't go into the details but at this stage, but you can look at them on the top of our website if you'd like to. And what we ended up with after a few drafts was a final version which had 59 questions within 4 categories. So demographics, diagnosis and etiology, treatment, and interagency contact. And what we were trying to do was merge together both management needs or service needs and clinical needs in terms of this audit, so we'd get information which would benefit all parties. Unsurprisingly, we gathered a large amount of data with 59 questions, and for those of you who've been talking already and created outcome measures, then you'd know that is quite a lot of information to collect in one hit. And so what I'm going to do is just focus on some of the highlights of the data that we got and how we use them. Demographics-wise, what we noticed pretty early on was there are about 50% more open cases in the child team than the youth team, which was quite a surprise considering, as I said, they had equal numbers of staff and roughly were sort of separated to cater for equal number of service users. So we had to look at this, and we had to kind of review individual caseloads, especially those of long-term service users. There are about 20% in the child team and 9% in the youth team who'd been there for more than a year, and about 4% in the child team and 6% in the youth team who'd been there for a couple of years. Maybe that was appropriate, maybe it wasn't, but that was one of the earliest plans by the SDG, was to look at that. 36% of people had been referred 2 or more times. Now, again, this might have been appropriate. It might have just have been episodes of recurrent illnesses, or it might have been for inefficient treatment the first time. So we needed to look at their cases as well, or their files, and see what had happened. And what we also noticed was that Maori and PI service users were definitely underrepresented as a percentage of caseload compared to the population. So 17% Maori, sorry, I did say 16% before it was 20, and 3% PI. Most service users had 2 diagnoses, and this can be a bit of a surprise to some people because in previous reports I've seen from CAMHS services, the most common diagnosis is no diagnosis, partly because people who are kind of doing assessments aren't trained to diagnose, and partly because we often tend to come up with more complex diagnoses, or we rely on formulations rather than diagnoses. But in our case, we had about 2 each. The most common of these was a V code in the DSM, so not a formal Axis 1 diagnosis called parent-child relationship problem. And the next common group of diagnoses were behaviour disorders. The SDG, and there was a whole other, we got a lot of information about other diagnoses that were present, and what we decided to do was look at the top 3 at least and see, do we have appropriate treatments for those according to the evidence base? Do we have the right sort of skill mix to kind of deal with it? If not, what do we need to develop and how do we do that? Etiologically, we have found a couple of surprising things. I mean, this may not be a surprise to some people in this room, but it was to us at the time. 34% of our service users, and these are children and young people we're talking about, had been exposed to some sort of abuse. The most common form was actually emotional neglect, followed by physical abuse, followed by sexual abuse. And this is not something which we were very au fait in dealing with, because as far as, for a lot of people, the mindset was if it's abuse, and i.e. sexual abuse, it goes to ACC counselling, it doesn't come into CAMHS. Whereas actually the people who are already within CAMHS had already been exposed to a fair amount of it, so we actually did need to address it. 46% of the child team and 36% of the youth team service users had 1 or more parents with a mental illness, only 20% of whom were receiving treatment at the time. Now, that again was a surprising finding to us. If you're biologically minded and you think, oh, well, these things are inherited, so that's not so much of a surprise, then that might explain it. But otherwise, it's quite a high number. It probably explains a lot of the difficulties that are going on for young people in terms of coping with what they're going through at home, and why only 20% of parents receiving treatment. Maybe the rest don't need it actively at the time, but we needed to look into that and also think about our links with adult services, so that we could make sure that if there are parents unwell at the same time as children, they also get their needs met. Surprisingly low amounts of financial, housing, drug and alcohol problems were identified. This could have been because we were missing them, because they're not really kind of things we'd focus on in a CAMHS service, but compared to the adult data, we thought we had to look a bit more into that. 1 in 5 of our clients had been bullied at school, and so we wondered about offering greater support to local schools and anti-bullying programs. For most adult service users, treatment involves medication at some stage. In ICAPS at the time we did our audit, only about a quarter of our population was receiving medication. The majority was being treated with so-called talking therapies or psychotherapies, and about a third of these involved more than one clinician. Now, for some therapies, such as family therapy, where you might have a group sort of situation with therapists, it is appropriate. You might have up to 5 therapists for one case. For the majority of our treatments, it would involve just 1 or 2 therapists. 80% of families in whānau were involved in care planning and treatment, which was good for us to know. But about 50% of people had family issues which were affecting clinical recovery. Small numbers, there were only small numbers of self-harm, about 10%, or attempted suicide, about 3% during the course of treatment in the population that we surveyed. 65% had up-to-date risk management plans. Not a great look, but I'm not sure how that compares with other CAMHS services around the country. Only 1 person had been treated involuntarily, and 7 had been admitted to hospital during the course of their treatment. 3/4 had HINOSCAs completed at assessment, and 47% during treatment. Again, I'm not sure if this is good or bad compared to other places. Maybe some of you could tell me. 20% had clinical outcome measures, i.e. non-HINOSCA ones, such as BDIs or anxiety scores or CONO scores measured at assessment, and only 8% during treatment. So we're not using these regularly, even though they're available in our departments. Should we be? Should we be looking at that more carefully? We wondered about that. Interagency contact-wise, about 85% of our young people had a GP, and finding one for those who didn't have one wasn't a big deal. 25% of them were receiving medical care from paediatric services in other parts of the hospital system. And apart from them, what we found was that, on average, our service users were connected with about 1.5 at 1.5 other education, social, cultural, NGO, legal services. So people actually not just coming to a CAMHS service, but they're coming to a CAMHS service plus at least one or two other places as well, on average. And overall, they're well serviced with access to treatment from a number of areas. But it also meant that we had to be aware of those links and maintain those links and those professional relationships with those agencies in an active manner rather than just assuming that they would take care of themselves. So we got a lot of data, and I've just presented a few bits. We got a great overall picture about what was happening in our service, and we certainly knew that we had to be more selective the next time we were doing KPP to narrow down the questions that we had and get some more targeted data that we could actually use. But from what we got, the key action points that we clarified were, or the things that we decided to prioritize as an SEG were questions about length of stay. Are some service users retained for too long? And could the review in conjunction with the CAPA process speed through throughput and reduce waiting times? Are there access problems for potential PI clients? Can we ensure a GP for 100% of service users so there's a better transition between primary and secondary mental health services? Can we agree on appropriate types and duration of therapies for at least the 3 most frequent diagnoses? Ideally for everything, but at least for the commonest things that we see. Can we improve the use of outcome measures and risk management plans? Can we support school anti-bullying programs, and should we be doing more to address other forms of abuse within our department? And should we be doing more to address parental mental illness? So, the joy of KPP is that it gives you the freedom to sort of shape your local inquiry to suit local purposes, and I know this is a message that David has promoted time and time again, but it's true. So you can collect, what we learned was that we could collect some data regularly on an annual basis, on a 2-yearly basis, which would give us an idea of how we're progressing over time, but we could also introduce other questions into the format if certain issues arose on one year but not on another. Clinicians can certainly become masters of their own service by producing the evidence to persuade funders and planners to fund training and other changes that are necessary. And it's KPP, it's been trialled in the CAMHS service now, and the experience is there, albeit limited, but it's there to share. Advice that we would have, kind of having gone through the experience, we're talking about the process of doing something, not just the content of it. We learnt a lot through the process, as you could expect. It's the first time doing something that was a new venture. What advice we'd have to others is ensure you've got adequate funding available for the process. Talk to funding and planning before you start. Keep the data set as simple as possible. It may not be possible to keep it simple, but if it is, do. Predefine the use for information collected, so know what you're going to use it for. Use existing electronic patient management systems to reduce the double up of data collection, because we collected all this manually. What we did was we had a questionnaire, a paper questionnaire. We had a day set aside for clinicians. It took about 10 to 20 minutes for each of them to complete each form, and they manually did that. So a whole day was spent by the service doing this. There was very little was put on sort of electronically or via computers, whereas actually a lot of this data would have been available on existing systems. It's just that we couldn't get it out to use for this purpose, and I think that's the same in the 2 DHBs I worked at. Data goes in and data just doesn't seem to come out, at least not back to the coalface where we work. Use tools such as SurveyMonkey to ensure that you get a complete data set and you don't get gaps, and also to simplify data transfer, and ensure timely feedback of results to clinicians, because that's what will motivate people to use the data. That's what will keep them interested. That's what will keep them invested in trying to... And all clinicians do want to do their best for the people they're looking after, but if you can provide them with that information, I'm sure that'll help them make the right decisions. And to also make sure you do review the value of any changes you implement following a process like this. So KPP Plus, the other reason for naming it that was because of Real Skills Plus, of course, which is the child version of Real Skills. It's a modified version of KPP, and from a CAMHS perspective, it's a useful vehicle, I believe, for data collection within CAMHS. When I talked to John Murray about this, some of you may know him, I was scared too, as some of you may realise why. And he instantly said, but we should already have data collection systems intrinsic within all mental health services. And I said, but we don't. That's why we ended up doing this. So his view was this was completely redundant, or it should be. And I agree with him. This should be redundant. We shouldn't need to do this, but we do at the moment. in the world that we live in. So I think, why is it different to the adult KPP? Well, okay, apart from the fact that it had more questions, I think CAMHS work is different from adult work, and we have greater emphasis on family involvement and interagency contact, as we've proven. There's more relevance. So I think we need an audit tool which reflects that, and this allows us to maintain the principles of KPP while doing that. And I think KPP actually has a strangely useful place alongside CAPA and Real Skills Plus. I'm not sure how familiar you are with those two documents, but CAPA talks about the process of clients sort of transition through a service, entry through to treatment, through to exit, and how to make it as efficient as possible. And Real Skills talks about the skill set and the knowledge and the attitudes that you need for professionals working within a mental health service. I think Real Skills Plus certainly gives us the advice about who should be working in a CAMHS service. CAPA talks about how people should be transitioning through services. What I think KPP Plus does, in addition to those, is talk about what should be done for people while they're in the service. I think they actually work really well together. So, just to conclude, I'd like to acknowledge Sarah Shaughnessy, who was the manager of the mental health services at Hutt Valley DHB at the time, who enthusiastically took on this crazy idea and supported us all through it. Dougal Sutherland, who's currently the manager of ICAFS, who was very much involved in the SDG and writing this up. Debbie Jordan, who was also involved in writing it up and setting the whole thing up, and who knew all about the Excel spreadsheets and computer wizardry that we needed. Sharon Morse, who helped her with some of that data transfer, the rest of the ICAFS SDG, and of course David. And I'll stop there. All right.